So I will speak about advantages and disadvantages of subgroup analyses in systematic reviews. And the question, it's not just on treatment effect, but mostly is the question, do treatment effects vary between different groups? So just to show which differences there can be, like in this example, we see that different subgroups of this, in this meta-analysis, there is no difference in effect. Then it can be like a quantitative difference, so it reveals an effect in all the subgroups, what in a different effect estimate. And very, very rarely there can also be qualitative differences in terms of in some subgroups the treatment is working and in some none, or it's even doing harms. But as I said, it's very, very rare. The clinical point of view of subgroup analysis is the question if the treatment effects are consistent across the subgroups, or in terms of individualized therapy, should treatments be used more extensively in certain subgroups? And are there potentially large differences in treatment effects between these groups? So, like for clinical heterogeneity. And subgroup analyses can be necessary in large simple trials or effectiveness trials. The statistical point of view is a little bit different because the information is mainly restricted by the multiplicity of testing and the low statistical power. That is usually a big problem of subgroup analyses. So the dice could mean for us, don't ignore chance effect. This is a very important statement, especially for subgroup analyses and especially when you do a lot of subgroup analyses. For the multiplicity and the play of chance, usually we have the type 1 error of 5%, and for independent tests there is a cumulative chance to have more than one false positive result. So for example, if you do 14 independent tests, you have more than 50% chance to get false positive result. If you do like 20 independent tests, you are already on 64% probability of at least one false positive result. I think. Is everybody hearing me? Do you hear me?
I can hear you.
Okay. Actually heard the entire presentation. Did anybody hear nothing till now? Okay. Okay. So I continue from here. So as I said, the probability is cumulative to have false positive results, and this is the major problem of multiplicity of testing. For example, you can do a statistical correction like the Bonferroni correction, where you divide the alpha error through the number of independent tests. So like if you do 10 tests, you have a p-value of 0.005 to be significant. But on the other side, this increases type 2 errors. So you can do like an overcorrection. So you can get more false negative results. That is the other side. This is a prominent example. This is the international study on infarct survival, published in the Lancet in 1988. It's a RCT. The population was patients with suspected acute myocardial infarction, and the treatments were streptokinase, aspirin, both treatments, or placebo. And the editors urged the authors to include nearly 40 subgroup analyses. So the authors decided to do a subgroup analysis of their own to illustrate the unreliability of such a high amount of subgroup analyses. So here you won't see a lot, but it's just to illustrate how many subgroup analyses they did. And this is here in red. They showed according to astrological birth signs, and in the end it came out that patients with Gemini or Libra, the placebo was better. And this is obviously just by chance. But if you interpret this and you do a recommendation for clinical reality, you would come to the end that you won't give aspirin to people with astrological birth sign Gemini or Libra.
I think you have a problem with the speakers.
Here's something.
So just stop for a moment. Okay. Still you can't hear me?
I'm just telling you that the phone line, they never called in.
We can hear you now on the computer.
Okay.
Well,
and now that I'm speaking, you hear me?
yes, I can hear you now. I don't know if my colleagues in the conference room can hear you.
Okay. I try to speak a little bit louder, so I hope it works better. So with this example, we see that it's important to be very skeptical if we do a lot of testing. These are other examples of subgroup analyses where the results were refuted later, like aspirin is ineffective in the secondary prevention of stroke in women, or beta blockers are ineffective after acute myocardial infarction in elderly people, and there are a lot of other examples. Speaking about the power of the studies, if trials are underpowered to detect subgroup effects, we have a high rate of false negative results. And as I can say in my experience, like I did now 2 systematic reviews in urologic oncology, and there is almost a problem that the entire trial is somehow underpowered. And so if the researcher do subgroup analysis, it's obvious that the subgroup analysis is underpowered highly. So frequently we use a type 2 error of 0.2, so we have 80% power. And as an example, if the entire study has 1,200 patients, we have 80% power. If we divide those now in subgroups and we have 250 patients, we have just 20% power. So we have a high rate of, or a high chance of false negative results. This is an example of a muscle invasive bladder cancer. This is just to illustrate, it was a small study, but this is somehow really common, and I saw it really a lot in oncology. We have a small study with altogether 91 patients, randomized to 2 groups. One got adjuvant chemotherapy, and one was just observed. And so they did subgroups with lymph node negative, one positive lymph node or more than 2 positive lymph nodes. And as you can see, the numbers are really low, so the power is really, really low. And in fact, this is not really valid as a real subgroup analysis. And another point that is often underestimated by researchers, that if we do like subgroups like this, the subgroups are not randomized. So we have an RCT, we have a subgroup analysis, but the subgroups are not randomized. It could be like you can do a stratified randomization to avoid this. This is another example. We are for muscle invasive bladder cancer. Here's the disease-free survival by chemotherapy type. So the subgroups in this meta-analysis are the different chemotherapies like cisplatin-based combinations, single-agent cisplatin and gemcitabine-cisplatin. And we see here that we have quite high heterogeneity statistically overall. And we see that the effects differ. What we can do, it's important to know that the sensitivity analysis is not the subgroup analysis. Somehow it's related and often confounded, but there are differences because the sensitivity analysis is just like I remove studies to see if my decision to include the studies was correct and to estimate the effect. In a subgroup analysis, I estimate the effect for each subgroup. So in the sensitivity analysis, I have no estimation of effect of the removed studies. And in the subgroup analysis, I do a proper formal statistical comparison across the subgroups. So in this case, it was shown that, for example, this study is a little bit of outlier. If you take it away, it's still statistically significant, because you could think about, okay, the study with the most impact could influence the result, that the overall result is not even statistically significant. So this is, for example, a reason to do sensitivity analysis. So the question is, are the findings robust to the decisions made in the process of obtaining them? And still always it would be perfect to specify a priori what we are doing, but often these issues are identified during the review process. So I already see the data and I'm asking myself, is this the right estimate of effect that I see? So afterwards I do a sensitivity analysis post hoc. And this is really often the case. This is another example, and this is clinically important because there's the rationale in muscle-invasive bladder cancer that patients with positive lymph nodes should get a chemotherapy, and maybe they can profit more than patients with lymph node negative. And what is interesting, investigating like heterogeneity, we see that overall we have quite high heterogeneity, and if we stratify now, we do subgroups of the studies with studies that have less than 50% of lymph node positive patients and studies with more than 50% lymph node positive patients. We have no statistical heterogeneity and we see a really different effect. So now the question is, do patients with lymph node positive disease profit more from the adjuvant chemotherapy? But there's a problem with this because here we are just on the study level. And we know this problem as aggregation bias, also called ecological fallacy. So it means that the effect on study or population level has not to apply to individuals, because the relationship across the studies may not reflect the relationships within studies. So this relationship is best measured within a study. And the classical variables are like age, sex, etc. So a solution to this problem could be to collect individual patient data. So you have the raw data of all patients with all the factors and covariates, and you can do a more appropriate analysis. But for sure it's a lot more work. So with the individual patient data systematic review, you have up-to-date data. You can decrease the publication bias. You can also decrease the aggregation bias. And you can categorize individuals by single or multiple factors. And this is more suitable than for the tests of interaction. The study design, how it should be, you should pre-specify in a protocol a priori what you want to do, which statistical analysis you want to do, which factors and variables you are measuring, and which subgroup analysis you want to do. So the less characteristics and the less analyses you do, the less likelihood you have of false positive result. This is due to the multiplicity of testing. So one way could be to stratify randomization by those subgroup variables. And this can be also very tricky in detail because, for example, I saw a study still on muscle invasive bladder cancer where the patients were stratified according to different local treatments in terms of radical cystectomy or radiotherapy or both. But the problem in this case was that the stratification of randomization was well done, but the doctors choose before the randomization which patient should get which treatment. So you have a selection bias before this step. So often it's really worth to look into the detail and to evaluate the risk of bias. So the trials should be powered to detect different effects in subgroups reliably, because usually I saw just publications where the sample size is calculated for the whole trial, but not for subgroup analysis. And it should be confined to the primary outcome, and usually is often analyzed on all outcomes or even on a lot more. Or in a lot of cases you don't know which outcomes were analyzed because it's not well reported. For the statistical analysis, the subgroups, you should not compare the p-values you obtain for the different subgroups. You should do a test of interaction. And you have to note that the false positive rate is obviously still 5% per subgroup. This is an example of a meta-analysis of 2001 of non-vertebral fractures in women with hormone replacement therapy. And if you see the data, you see that in studies where women's mean age was less than 60 years, you have a reduction of fractures of 33%. That is also statistically significant. And in studies where the women were older than 60 years, in mean there was just a 12% reduction, and it was not statistically significant. 2 years later, Altman and Plant rechecked this data and did a test of interaction, and they saw that the test of interaction is not statistically significant. So here we have no difference in treatment effect. And if you just see this data here, it could be that you get the recommendation to give this therapy just to younger women. And the test of interaction, as I said, is not comparing the p-values, but compares the means of treatment effects to each other. This is also an example I had a few months ago. This down here is a Cochrane review on neoadjuvant chemotherapy for muscle-invasive bladder cancer, and this is one of the included studies. This was the biggest included study with totally nearly 1,000 patients, and the whole systematic review and meta-analysis had 3,000 patients. So they did a test of interaction. But the problem is they reported we planned exploratory subgroup analyses in subgroups defined by all characteristics of patients recorded at randomization. So we still don't know how many patients are included in this analysis, because sometimes data are missing and we really don't know who is included or not. So we don't know the number of patients included. And in this case, we see that, for example, patients with this means that with a higher grade of tumor the therapy is more effective in the patients with a higher grade. And also the renal function, we see a significant effect. So interpreting this data, this would mean that the better the renal function is, the better the chemotherapy works. For the tumor size, for example, the bigger the tumor size, the chemotherapy is not more effective. And if you look now at the systematic review, and this was made with individual patient data, they restricted these analyses just to the studies with combination chemotherapy, because we saw there are different effects because different chemotherapy regimes. And we see, for example, that in the trials, the grade was available in full for 4 trials, but tumor diameter and renal function was only available for 1 trial. And the authors also provided a table where you can see for how many patients this data was provided. But when you look really in detail, it's not one-to-one. So there are more included patients, and I could not really estimate how many patients were taken into this analysis. And here the results really differ. The grade is not significant, whereas this here is highly significant. And more interesting is that it's written that the renal function was only available for 1 trial. So it must be this trial, I guess, but here it's not significant and here is significant. But as I said, the number of patients differs from the reporting, and also the tumor size in the meta-analysis is statistically significant. So we have a high uncertainty, but I would say that the individual patient systematic review meta-analysis is methodologically a lot better than the single study. So for the reporting, the investigators should report all subgroup analyses they did, and not just the statistically significant ones. And this is rarely done from what I've saw till now. And if the analyses were made post hoc, they should be interpreted even more cautiously. So this is now a picture of the real world. Sun et al. In 2012 published a systematic review, and they published 10 criteria to assess the credibility of subgroup effect. So they are questioning were the variables measured at baseline, was the subgroup stratified at randomization, was the subgroup hypothesis specified a priori, was the subgroup analysis only on a small number of subgroup hypotheses tested, so 5 or less, was the test of interaction significant, was the significant interaction effect independent when they made more tests, and from the context, was the direction of subgroup effect correctly pre-specified, this is rarely done, and was the subgroup effect consistent with evidence from previous related studies, and also was it consistent across related outcomes if different outcomes were measured. And also important, is there any indirect evidence to support the apparent subgroup effect, for example, biological, rational, laboratory tests, animal studies. So, for example, when you do a systematic review and you just look your included studies, so you can have a sort of bias in this. So if there is also evidence outside your systematic review that provides a biologic rationale, so the subgroup effect you see could be more credible. So now they sampled RCTs of 2007 of core clinical journals, and they had high and low impact 1-to-1. And 64 of the 207 sampled made claims of subgroup effect. So 31% of those sampled RCTs made claims. And of these 64 RCTs, nearly a third claimed for the primary outcome. Nearly all variables measured the variables at baseline. Only a fifth did the stratified randomization. Nearly half pre-specified the hypothesis, and just 6% correctly pre-specified the direction, and nearly the half tested just a small number of hypotheses. So we see that what we say in theory, how it should be, and how the reality is, there is a big gap. They made tests of interactions, and only 9% of those claims in the tests of interaction were statistically significant. In 1/3, it was the replication was documented already, that the effect was shown previously. 30% they had a consistency of effect across the related outcomes, and just more or less 1/5 provided a compelling indirect evidence for the effect. Of these 64 RCTs, 19 made more than one claim of subgroup effects, but just 5% of this checked the independence. So only 3 out of 19 RCTs checked the independence of those claims they made. So if you see, 84% did meet 4 or less out of those 10 criteria mentioned before, and 20 RCTs of the 64 made strong claims. So they said there is a strong effect of this, so they believe in this subgroup effect, and more than half met 0 criteria out of them, and 15% met more than 5. So Oxman replied in an editorial on this paper, and he said we could maybe use a simple rule of thumb. So he's questioning, are the results of the subgroup analysis and the overall analysis different enough that they would lead to different decisions? If yes, you can apply those criteria I mentioned before from Sun et al. And if no, you don't have to apply the criteria because they are not relevant. So taking together and speaking in a metaphor, so if you are a researcher and you are really hungry and you really want to find this cheese and you see different cheeses and you really want to find them, just take a healthy dose of skepticism. Thank you.
Thank you very much, Peter. Are there any questions? We have one